We have the privilege today of listening to Dr. Thomas Caskey. He's professor of molecular and human genetics at Baylor College of Medicine in Houston, Texas. Dr. Caskey is board certified in internal medicine, medical genetics, and molecular genetics with 25 plus years of patient care experience in these specialties. He's a member of the National Academy of Sciences, the Institute of Medicine, the Royal Society of Canada, member and chair of the Board of Health Science Policies Institute in Medicine, and past presidents of the American Society of Human Genetics and the Human Genome Organization and the Texas Academy of Medicine, Engineering and Science. He's an editor of the Annual Reviews of Medicine. Dr. Caskey was the director and chief executive officer of the Brown Foundation Institute of Molecular Medicine at the University of Texas Health Science Center in Houston. He has also served as senior vice president of human genetics and vaccines discovery at Merck Research Laboratories, West Point, and as president of the Merck Genome Research Institute. Dr. Caskey has received numerous academic and industry honors. His genetic research has identified the genetic basis of 10 major inheritable diseases, many yet to come. He also opened up the understanding of triplet repeat diseases, such as Fragile X, myotonic dystrophy, and others. His personal identification patent is the basis of worldwide application for forensic science, and he is also a consultant to the FBI in forensic science. His current research is focused on the genetic basis of schizophrenia. Currently, he's taking part in the development of personalized medicine as it evolves into what is now known as precision medicine. He is a young partner at Essex Woodlands in Houston, Texas, and member of the United States National Academy of Sciences. He's recognized worldwide as a leading physician, biochemist, and geneticist. Last but not least, he was one of the lecturers this past November at BioMonterey Summit organized by Dr. Luis Eugenio Todd.
Well, thank you very much for that generous introduction. Since I lectured here in the fall of last year, my research has progressed in looking at rare and interesting cases for precision medicine diagnosis. And what I have elected to do this afternoon is to tell you about 4 cases. And I think that they will illustrate the power of the new technology, and I hope will convince you of the utility of this technology. And I will give you 2 examples of cases in which the diagnosis and utility led to correction of the defect. So let me start first of all with the area of cancer. And this is a very personal case that I've been involved in. It's one of my best friends who unfortunately developed squamous cell carcinoma, a skin squamous cell carcinoma that was at the back of the ear. Very small lesion. Surgically removed. They thought the problem had been solved. The margins on the surgery were clean. So no one suspected that this was a highly malignant and invasive cancer. He came in for a medical examination and follow-up, and when imaging studies were carried out, he had metastatic lesions in the chest, 4, a rapidly advancing squamous cell carcinoma. So now we're dealing with two problems. One is, what's the basis of the carcinoma of the neck? Is it virally induced or is it endogenously created? And secondly, what is the character of the metastatic lesion so that we can begin to select the proper therapy? So in the first case, as you well know, head and neck tumors are frequently associated with HPV infection. And they are highly malignant. In his case, we were fortunate that the tumor, the primary tumor, was HPV negative. So now what do we do about trying to identify the proper drug for his metastatic disease? Surgery is no longer an option. We have to find the match of the genetic alterations in the tumor with potentially a therapy that will interfere with the growth of the tumor. So what we did is we carried out directed biopsy of the metastatic lesion in the chest, one of those, and we carried out molecular analysis of that tumor. Now, what do I mean by molecular analysis? We did a variety of things. The first one was to sequence DNA. What is different about the patient's normal DNA and what's changed in the tumor? And we were able to identify a plethora of alterations that had occurred in the tumor that had the potential to be causative of expansion and growth of the tumor cells. We secondly carried out sequencing of the RNA from the tumor to ask two questions. One is there an upregulated RNA in the tumor? And secondly, are there mutants that we find within the messenger RNA? A third component came along at a later stage that made use of our information, and I'll come to that in just a moment, another therapeutic approach. So what we were able to identify in the tumor was a markedly elevated level of epidermal growth factor within the metastatic lesion. It was not present, of course, in the normal tissue of the individual. So we had an opportunity now to look for targeted drugs to epidermal growth factor. And there are, fortunately, FDA-approved drugs that hit that target. So we were able to place my friend on that therapy, and I'm happy to report that within 4 weeks of the time he was placed on one therapeutic, we had no evidence of metastatic disease within the chest or any other area. So the drug identified by genetic sequencing, matched to the target selection, resolved and eliminated the tumor. Now, that's the good news on this story. The news we have to be prepared for, however, is the tumor will develop resistance to this drug. And that is extremely well documented in the literature. That the drug works, it works well for 6 to 9 months, and back comes the tumor. So we now have taken a second strategy for the tumor, which is based upon RNA sequencing of the tumor. There have been remarkable breakthroughs in the last 3 years in the use of immunomodulation therapy in cancer. There are 2 drugs on the market now, CTLA-4, which can stimulate immune response, and PD-1, which will unmask a tumor cell so that CTLA-4 cells can attack it. These new drugs have been miraculous in the area of melanoma, where typically survival is 6 months. These new drugs give patients cure settings at 3 and 4 years. So altering only the immune system so that the immune system attacks the cancer provides an entirely different strategy of therapeutic for this disease. So how do we get set up to be able to provide him with that therapeutic? One isolates from the individual T cell competence. You now add to that cell mixture in culture peptides that correspond to proteins that are mutant and highly expressed in the tumor. So the plan is to stimulate the T cells to attack the mutant proteins that are within the tumor. We probably had 10 proteins that we could easily identify by the sequencing of the messenger RNA. We were able to predict on the basis of the knowledge of those genes which ones were on the surface of the cell, and therefore use the peptides of those selected genes to create a T cell killer inventory from his own cells. That has now been completed. We used 5 peptide stimulants for proteins. We were able to train or educate his T cells to 2 out of the 5, and those cells now are ready to be re-administered to him at the end of the month. So while we've eliminated the tumor by targeted therapy, we're coming in with a second strategy of immunotherapy. Every bit of this was driven by DNA sequencing of DNA and RNA, and using the most novel approaches to be able to direct therapy to exactly what's wrong with the tumor. So we're very proud of this. I think we're going to end up with a cure for my friend. That's pretty satisfactory. Certainly, it's looking good now. Now, let me tell you a downside of the older method of treating a cervical cancer. And standard of care, as you read the literature, will be the use of irradiation in combination with cisplatin. 2 pretty toxic therapies. Remembering, we've got to irradiate now a broad field of where the tumor has metastasized to. The patient underwent maximum irradiation and maximum dosage of cisplatin before we did the sequencing. We got drawn in when things failed. Our sequencing results identified that the patient had a P53 mutation null status. What does that tell us about cisplatin and exirradiation? They don't work. So the patient was put through horrific therapeutic state-of-the-art based upon the conventional studies of many years prior to this, only to discover that his tumor is unresponsive to those 2 therapies. So you can see the benefit of using the molecular studies to select the therapy. In this case, we got fortunate. I mean, you could say, well, you're lucky you identified it. But you know what? We looked. If we hadn't looked, I would have had no options in therapy. So I use this as an illustration of the selection of the right therapeutic matched by DNA and RNA sequencing. I can tell you this is not easy work. It is incredibly informatic dependent. You'd better know how to deal with computers, and you'd better know how to deal with DNA sequencing and RNA sequencing information to be able to analyze such results. So while the technology of sequencing was important, equally important was the information technology strategy to extract the data. And then, of course, we were fortunate that we could use innovative new therapeutics on the case. Now you can say, this sounds too hard, Dr. Caskey. I mean, you've only talked to me about one patient, but it points the direction to what's going to be done in oncology. This is the strategy of what will be done for the future. Undoubtedly, we'll get faster. Undoubtedly, we'll get smarter. Undoubtedly, we'll have more therapeutics to apply to colon cancer, breast cancer, cervical cancer, to deal with cancers that come from the head and neck, pulmonary cancers. So I point this case out to you as an area of the future, but the future is here. I've illustrated how it's worked for one patient, and it will work for many others in the same manner. Think about this for your own career selection. Now let me tell you about a second case. And the spectrum is different. It's a little child. This child was developmentally delayed, small in size, had a number of different feeding disorders, but was being managed, I think, as effectively as the doctors could manage the patient out of Stanford. In Stanford, since they had no diagnosis on the child, referred the child to our diagnostic laboratory to carry out whole genome sequencing on the child. Whole genome sequencing, I mean whole exon sequencing. We carried out the study, did not find anything that had been reported in the literature, and reported it back to Stanford. We had no result. I was out and in California in January attending a scientific meeting when the mother called me and said that she had heard I was here in California and would like for me to see her daughter to see if I had anything that might contribute to the case. So I'm not a pediatrician, I'm an internist. But I said, yes, I'll be happy to see your child. So I examined the little child, and she's a child who has been gaining in milestones over time. She's not doing this. She's getting a little bit better with time. Speech, very poor. Comprehension, very poor. Small size for sure. Feeding difficulties. And I could not immediately identify a syndrome. It just didn't fit with anything I knew in the literature. So I returned to Houston, and we took a different strategy. When you carry out exon sequencing, you identify in each of us around 10,000 variations. Most of them we have no idea what the significance is. But others, we can go against databases for disease or publications in the literature, and we can match the sequence with the disease. Well, we had failed in that. So again, I go back to bioinformatics, selected a young and motivated young bioinformatician in training in our program. And I said, you've got to go back and search the unknowns. You've got to look at them hard. And I want you to do the following. I want you to look at every one of the unknowns that has what I call a hard hit on the mutation. It's a deletion, it's a duplication, it's a nonsense mutation, it's a clear mutation that will influence that protein. We pulled up probably 25. In genes, we had no idea what they did. So we then took the strategy. I told the bioinformatician, I suspect this is a rare new mutation case. So what I want you to do next is I want you to look at every one of these mutations that you found and ask the question, does one of the parents have that mutation? And when we did that, we found one gene in which the parents were perfectly normal and the child had the mutation. A new mutation, rare disease. Then we looked up what the protein was and how it had been described in the molecular biology literature. No patients reported. And what we discovered is that this was a critical protein in DNA folding. Therefore, it affected all cells. So this child's growth pattern, the limited development of intellect, the difficulty in the autonomic system for swallowing, digestion, all fit. So what was the benefit of this research? The benefit is we made a new discovery. I was able to go back to the family and say, look, this is a new mutation event. It's not going to be a problem for your daughter. It's not a problem for any other family members. And that was something of high concern to them. This is a one-time event, will not happen again. So there was satisfaction in one, getting a diagnosis and being able to give them this information on family risk. Now, will I ever be able to develop a therapeutic for that child? Probably not, because the damage has been done. The damage was done in the early stages of development of the child. So you can see the study of an acquired neoplastic disease, you get a resolution, we got a therapeutic. In the case of a rare pediatric case, we made a one-off diagnosis. There is no other child reported in the literature that has anything corresponding to this. And we will contribute this information to the databases that exist around the world to see if a second or third case is identified. So that's the second example that I wish to tell you about from the time I was here in the fall. Now let me tell you about two more cases, each coming from the young executive group, which you'll remember I talked about. After we completed that study, we then invited their doctors to come in for sequencing. And the story is pretty similar with the doctors. There were about 100 doctors invited to come in to be sequenced, and about 50 of them decided to do it. And just as with the YPO members, the motivation of those doctors to come in and be sequenced was they were seeking genetic information for illness that was either in their family or they had. That was exactly what happened with YPO. So I'm going to tell you about two cases. The first case is one that anyone who's been trained in O'Slerian internal medicine will understand. The patient had the following. It's a 55-year-old male who had the findings of thyroiditis and thyroid failure, had diabetes 1 due to pancreatic cell distribution, an autoimmune disease, just as the thyroid disease was, had the occurrence of a third autoimmune disease, pernicious anemia, and a fourth heritable disease, which was a GI disease in which you have excessive cytokine activity related to the disease, which does destruction to the GI tract, gastroenteritis. There was one other feature of the case which was very unusual, and that is multiple lipomatosis. The patient had all over the surface of the body lipoma that were this large, all over, chest, arms, etc., etc. Now, as I said, if you were trained as an internist in the Oslerian strategy, rather than making a list of all those diseases, you'd say what's common to them that can explain every one of these illnesses. And the thing in common is autoimmunity. Now, the family history was negative on this patient. He had no children, so I had no opportunity to study genetic traits. But there's an inventory of genes which are mutant that are causative of autoimmunity. The list is probably about 10. So we carried out exon sequencing on him, and we were able to identify one of the most rare of these gene defects in him, called AIRE, A-I-R-E. It is a transcription factor that inhibits the immune system. So this gene, when defective, has no way to control an immune response. The immune response is excessive in the individual. So we were able to successfully identify the causation of what looked like 5 diseases caused by a single gene. And the next question, of course, this executive asked, what do we do about it? What do we do to treat it? Well, we've got end organ damage now to 5 different diseases: thyroid disease, diabetes 1, gastroenteritis, B12 deficiency, you name it. Well, we had solutions to the thyroid disease. We had solutions to type 1 diabetes. We had solutions for the pernicious anemia. And my question to him was, what bothers you? And he said, my joints bother me, my rheumatoid arthritis, and I think I failed to mention that one, rheumatoid arthritis, and my GI complaints. Well, there are monoclonal antibodies now available which miraculously treat rheumatoid arthritis, TNF monoclonal antibodies. So we have tried the TNF monoclonal antibodies on him, looking for relief in 2 organ systems, GI and rheumatoid arthritis. And the result is positive. That is, the monoclonal antibody works, gives him relief in 2 systems. I didn't solve the problem of the transcription factor, but I had a therapeutic that worked downstream. It worked at the end organ. So this patient, basically having this extremely rare disorder, has now had a diagnosis which enabled me to select a single therapeutic agent, and he was able to get relief of the disease. So that was a very satisfying moment. Now, to introduce confusion into this result, I had a second patient, thyroiditis, type 1 diabetes, rheumatoid arthritis, vitiligo, B12 deficiency. No discovery in her. So it's one of the genes that we have not identified that have led to her autoimmunity. It's an opportunity for discovery, but it's not the same gene that we got relief from the first. So that just shows you the complexity of using diagnostics in a complex disease. We resolved basically 5 diseases by the identification of a single gene that altered an immune regulatory system and gave rise to the disease. A very satisfactory outcome for one patient, but no answer for the second. Now let me finish with the 4th case, again an MD, who had been perfectly in good health throughout most of his medical career. And I would say At age 55, I can remember being in meetings with him, and he was perfectly fine, carrying out his pediatric practice, very active individual. And then around 60, he began to develop a profound muscular weakness to the point that he cannot maintain a vertical position at this point. He can sit in a chair and he can work from a chair, but he cannot stand up and be erect. And he's getting progressively worse in the ability to carry out his own profession, and is getting more and more debilitated. We carried out exon sequencing on him. I had no idea what we were going to deal with. I thought perhaps he had amyotrophic lateral sclerosis. He might have had myasthenia gravis. It could have been any number of diagnoses. But I had one key piece of pathology information. He had had a muscle biopsy, and the diagnosis on the muscle biopsy had said central core myopathy. Now that's a disease of children. That's not a disease that we see in adult life. But nevertheless, we carried out sequencing on it and were successful in identifying a damaging mutation in a gene known to cause central core myopathy. Only one of two copies. In children that have central core myopathy, the two genes are mutant. Now I can tell you there are now at least 5 diseases I could name in which we used to think a single copy gene doesn't cause a problem. It's a recessive trait because only the affected children will have the disease. We now know that in adults, these genes are causing damage. And so you have a later onset of disease. Now, the classic one that everyone will identify with would be type 2 hypercholesterolemia, LDL receptor defect. If you have a double dosage of the LDL receptor defect, you get a myocardial infarct at age 6. If you have one copy, you get your myocardial infarct about 40 to 50. So there's an example of heterozygosity or hemizygosity giving rise to an adult onset disease which normally occurs in the pediatric age. We've now identified several cases like that. Gaucher's would be another example. So in this case, we were able to identify a gene known to cause central core myopathy in an adult that occurred in a heterozygotic state. A new discovery of the character of that gene. Now, what are we going to be able to do about this is something we're worrying with right now. We now have a diagnosis. Can we develop therapeutics that would be helpful to him? And that's something that I don't have an answer to, but it's being worked on. So I thought what I would do is illustrate to you the power of the genetic approach, some reward that we've had in being able to get an accurate diagnosis and an accurate therapeutic approach to the patient. And then also to illustrate to you that life is tough. We don't have as many therapeutic options as we do diagnostic options. So the field is very bright for the field of genetics, for discovery, for those of you interested in basic science. It's also very rich for the opportunity for the development of new therapeutics. And we now are beginning to see the connection between a diagnosis and a new therapeutic that matches and solves a problem, so-called precision medicine. So I hope you give serious consideration to genetics and these fields for your later studies. And remember that I've told you the bioinformaticians hold the secret to much of this. Thank you so much.
We open now a brief space for us to ask questions. Hay ahora un espacio para preguntas.
Yes. Yes. stand up and turn around. I'll hear you. I'll hear you well.
Yeah, I would say that now that we are in the era of precision medicine, in fact, Obama in his last State of the Union referred to it, right? And taking the opportunity that we have a lot of experience in this area, can you remember when was the first time that a diagnostic test was derived from genomic sequencing? What was the first example of the first personalized medicine test?
Well, I'm pretty sure I'm accurate. The question is, what was the first diagnosis made using genome science sequencing? Okay. And some of you may know Jim Lepsky, who's one of the well-known faculty members at Baylor College of Medicine. And Jim has a very strong history of Charcot-Marie tooth dystrophy. It's a muscular weakness in the lower extremities and upper extremities that progresses over time. He had a positive family history of it. There were many family members with it. So he was the first to be sequenced and was able to identify his own gene defect. And so that would be, I think, one of the very first examples. Now, there are some examples that have occurred out of the Seattle program in which they did trio analysis, that is mother, father, affected child, compared the sequence. And they were able to identify the defect probably now in 5 different diseases of those children that had disease. So that was a different strategy. Jim's was just sequence my own DNA and examine it. So those are examples I can give you. Yes.
Hereditary cancer in Baylor?
Say that again.
Do you have clinical trials for hereditary cancer at Baylor, like for example for Walsh syndrome or Rett syndrome or something like that?
We do not. The only clinical trial I know we're involved in right now with cancer is the BRCA1, BRCA2 identification of risk. So that's breast cancer. And there are now a few reports out that if you carry a BRCA1 or BRCA2 mutation, that anti-estrogens have suppressed the appearance of the neoplasia. I don't know whether that's going to hold up or not, but it looks promising that if you identify the risk, you may have a therapeutic to intervene on the risk.
Well, I have a little question about the process of creating the antigens for the first case you talked. You talked about a way to stimulate the immune system in order to attack the cancer cells. So how did you prepare the antigens? How did you produce the antigens used to stimulate the system of the patient?
Okay. The process that's being used currently is to take the sequence information off of RNA-seq and look for those genes that are highly expressed, localized to the membrane, and preferably would have mutations in it. Most of the genes that come out of a tumor analysis will have mutations with them that differ from germline. So that's your inventory. And now you have to intelligently select which ones of these am I going to use to try to train the T cells. So we isolate T cells from the patient, place them in culture, and then we've made a cocktail of peptides from each of the antigens identified. In this case, we did 5. And then put those in culture and propagated the T cells. When we got to the end of that process of stimulating the cells, growing the cells, we then asked the question, what are the T cells directed to? And the T cells were directed to 2 out of the 5. Typically, they will get 3 to 4 out of 5 in the trained cells, and those are the cells that go back into the patient. Hope that.
Thanks very much.
So it's a cocktail of peptides.
Well, in cancer, we know that we have in one tumor, in a particular tumor, we have a lot of mutations. We have millions of cells, and for example, in breast cancer, we have deletions translocations, inversions, a lot of mutations. But sometimes, or I don't want to say always, we have that in a cell is a mutation, a particular mutation, and in another is a different mutation. And when we make the diagnosis of that, well, we are surprised that the tumor is very different to a cell to another. And what we can do with this problem? Because we are going to treat the tumor, we are going to destroy the tumor. That's the idea. But with this problem, we can't make an objective, a particular objective, because there are a lot of mutations and are different in a cell than another. When we look at the cells, at the tumor cells of the breast cancer, we look at disaster, and this is complicated, and how we can treat this problem.
All right, I agree. You've hit the heart of the analysis, and that is you have large numbers of mutations that occur within cancer cells because cancer cells have lost the DNA repair mechanisms typically. So you're spinning off mutations at a high rate within the tumor. So there are many genes that are mutant that are, we refer to as bystander mutations. They are not the mutations that drive the cancer. So those mutations that are loss of function, we typically don't worry about. It's those mutations that are gain of function that would accelerate the growth of the tumor that we focus on for developing therapeutics. Now, it's still a major challenge. So let me tell you about the project that's ongoing with one of the young investigators at Baylor, and I think this is really smart. He has a cloning system, a viral vector cloning system, that will enable him to put as many as 50 to 100 different candidate genes into a library. Those genes are then, that cocktail of viral vectors is then placed into a cell line and creates a tumor. The tumor in nude mice. He then takes the tumor from the nude mice, and by DNA coding of the vector found in that tumor, he knows what that gene is, because he can code each of the viral vectors. So he has developed basically an analytic tool that'll let him look at 100 different candidates and look for a tumor. And I think this is really smart. We'll probably begin to get the pattern of those things that we just ignore. You see it a lot, it doesn't do anything. And we'll get a cadre of genes that are predominantly the drivers of neoplasia. Vogelstein recently in Science has published a paper that says all tumors are mixtures of drivers. And that's the reason for resistance. It's not that there's a mutation that leads to the resistance of the drug. It's the fact you started out with a mixture of cells that were able to propagate. And so his ideas are we need to identify all the propagating genes and probably hit with multiple therapies. It's what we do with HIV and hepatitis C.
Thank you.
Yes. So I know you didn't talk about HIV, but I had this idea that I wasn't sure if they're currently partaking in doing this, but HIV, as we know, like goes into T cells, right?
Mm-hmm.
And it goes into them and creates it pretty much causes them to explode, right?
Mm-hmm.
So would it be possible to take a recombinant antigen or a vector and place it into a T cell while HIV is still in there and inhibit the protein synthesis of HIV while it's still in there? That way, HIV can't create any more any more viruses, and in that way stop HIV.
All right, it's an interesting strategy. The problem you've got there is how do you hit all of the HIV infected cells?
Well, based on what you were saying before on the theory that, or the experiment that that student at your facility was doing in identifying, well,
The
in this
mutation.
case, cancer. But
Right.
if we could do that for HIV and then use this technique, would it be possible to, in a way?
Well, you know, I happened to be at Merck. I was senior vice president at Merck at the time we developed the HIV drugs. And I was the one that developed the HIV vaccine that failed. So admit failure. But what we learned from the development of the drugs is that the cells replicate so rapidly in HIV that they will move away from the mutation target. So we were not able to keep up with the mutation rate. The only way we solved the problem with HIV was to hit it with 3 different drugs, you know, different targets. And then you were able to get control of the disease with no cures. Now let me tell you what's being worked on right now that I think, though, is an alternative strategy. I just read the paper in, coming over here, in Nature. Yeah, Nature this week, in which they had delivered in a viral vector, I think AAV, delivered in AAV, monoclonal antibodies directed to HIV. And they were able to demonstrate in primates that if you did that, you block primate induction of SIV. So that's one gene therapy strategy that looks like it's worked in mammals as a preventative. Now, there's another strategy that I think is going to be fascinating to follow. And it relates to the PD-1 discoveries that have been used in cancer. We do not know why our CTLs that come up in HIV, and they do, why they don't knock out the nidus of the HIV infection. And no one has investigated so far whether it has a blocking mechanism like PD-1 so that the CTL cells cannot hit it. But now the tools are available. You'll be able to ask the question, if I give the patient PD-1 and have an immune response already in the patient, do I knock the nidus out? I think you can read about that in a year or so. My bet is it works.
Doctor, excuse me, I have another question. It's well documented in the literature that the cancer cells has an amazing adaptability of the ways we have to treat them.
Yeah.
For example, when you attack a cancer cell, and it's like a natural selection, many cells can have the ability of change the expression of their genes in order to avoid the ways we used to treat the patient. So when we're trying about an immune therapy, how can we perform the treatment in order to avoid the ability of the cancer cells of mutate and update to our treatment?
Okay, that's a great question. You should come and work in cancer with us. I think one of the features of the immune modulation in cancer is that we are stimulating the immune system to develop an inventory of CTL cells. So it's not one, it's an inventory. Furthermore, so it's like multi-drug therapy if you stop to think about it that way. Now, the advantage of the immunomodulation strategy is you can give this one single agent and it's tolerated very well, and you hit the cancer with multiple therapeutics in a non-damaging way. Now, let's go back to the precision medicine diagnosis. Each of these drugs that I've mentioned are receptors, kinases, MET. I can go down a long list of them in which we hit them with a drug. We cannot do what we did with HIV and hepatitis C, where we give 3 drugs at one time. Those drugs for HIV and hepatitis C were designed for safety. You can get by with giving 3 drugs. There's not a single agent that I'm aware of right now that does not bear some toxicity. We just can't, we cannot hit the patient with 3 drugs. So that's the answer. Precision medicine, I think, has got a major problem until we get really safe drugs. Immunomodulation looks pretty good. Thank you.
Dr. Caskey, I met Albert St. George 25 years ago. He was a Nobel Prize. He was the one who synthesized vitamin C. It was a Lasker Prize because he described the actomycin. He was here. He was 92 years. He was married at 47 years old.
That's why he lived to 92.
He came here because he wanted to do some research, clinical research. He had proven in mice that the oxidation process changes the energy of the cell, changes genetic, and produce cancer. He developed cancer in mice very easily. My question is, there are many cases of cancer that really we are making a good diagnosis.
No, I think we're living longer.
And second, the oxidation process of the immune society, many food and many oxidation, nutrition in the egg, can produce mutation in genes?
Yes. If you look at the process of immune modulation, the initial reporting on this probably goes back 20 or 30 years. So there were some hints that the immune system could suppress a cancer. Now, the one I love to use as an example when I'm talking to patients about this, if you stop to think about a pregnancy is a cancer. Why does the baby not kill the mother? It's uncontrolled growth. The immune system protects the mother. So, I mean, that's the best example I can use of something growing rapidly that is under control. And that's what happens in cancer.
The child is not metastasizing. No metastasis from the child. Well, I think this will be the last question for you, Dr. Caskey. First of all, I would like to thank you again for coming here to Monterey again, and thank Dr. Todd for helping us in this situation. Dr. Caskey, as he's already said, he was here in the fall of the last year. I'm glad this is the last question because I will make a complete shift on the topic, because we have been talking so far almost on the impact of genetics and genetic studies on autoimmunity, immunity, and this immune modulation, which is my own interest, and cancer. But now I would like just to ask you, Dr. Caskey, about your insights and experience on some other diseases that are of high impact here in our society, and how this precision medicine that you have been developing and working with help us in this situation to know and to prevent these diseases. And I'm talking about specifically on diabetes type 2. This is a scourge here in our country, and it costs a lot of money, costs a lot of health, and costs a lot of disability. And this is a real problem. The prevalence of that is reaching soon the 10%. I have heard, please correct me if I'm wrong. In the adult population is reaching the 10%. This is correct. Something that is very valuable. So if you can just to close this, to tell us about your experience and insights on that regard.
Okay.
We'll appreciate it.
All right. Thank you. See, as you well know, type 2 diabetes, which you can put under the general category of insulin resistance, okay, can be caused by, at my last count, there were 15 genes that could affect that. So we know there is a genetic basis for type 2 diabetes. this genetic basis has not changed in 10 years. I can tell you that. So this is the classic situation of environment and genetic risk that has interfaced. And so the likelihood is high that it's going to be behavioral modification that has the greatest impact on the incidence of type 2 diabetes. And that we will understand certain cases of genetic basis of type 2 diabetes for which there will be therapies. I can tell you among my YPO executive group, I had one of the female executives that came in. She was trim as she could be, very athletic individual, and she had significant mutations in diabetes 2 genes. And I asked her, you know, how are you so trim? And she had no evidence of type 2 disease at that point. This lady worked out 1 hour a day, and she maintained strictly dietary control. Now, that was just her habit. That was her behavior. So she had literally corrected her genetic predisposition to diabetes by behavioral modification. In all likelihood, that's probably what we're going to have to do in our society, because the genes haven't mutated in the last 10 years, that's for sure.
Do you have last question? Okay.
As long as it's not hard.
No, it's not hard. It's actually more about a currently topic. You mentioned you are making some sequencing at Baylor College. But I wanted to know, is it commercially available, or is it only like research with a research basis? And second of all, I know the prices of this technology is getting every time lower, but I think it's quite not yet affordable. So how much time do you estimate for us to be able to make this kind of exome sequencing?
Right. Well, first of all, it's occurring right now. The cost of doing whole exon sequencing runs around $5,000. And we're doing currently around 3,500 to 4,000 cases per year. Now, what type of cases are we doing? We're doing undiagnosed pediatric diseases. I mean, if you use two technologies, copy number variation, which is on the chip, versus exon sequencing, you will make a diagnosis 45% of the time of those undiagnosed cases. Now, $5,000 is pretty cheap compared to running up a bill of $200,000 on things the child never needed to have done. And so that's what the cost analysis is coming out right now, is that first line would be to do the genetic analysis, make your diagnosis on the 45% of the cases, and then you can carry on with other diagnostic studies on the ones you haven't met. So you'll save a ton of money by first turning to genetics on those cases. It's reality now. We do it from all over the world. What we do is the following. We do the child only, and then when we make a diagnosis of the causation, we will come back and reconfirm it by a different sequencing technique and check the two parents for it at that time. Saves money.
Thank you, Dr. Caskey, again for your speech and your dissertation. I would like just to give you this letter of acknowledgement and recognition. I would like to read it. It is my privilege. Hereby acknowledge your dissertation about genetics for disease prevention given at this center of the Autonomous University of Nuevo León, Universidad Autónoma de Nuevo León, on this date. And we appreciate very much your willingness to share your ample experience and knowledge on this field. And of course, we look forward to host you again soon, Dr. Caskey. And it's also my privilege to present to you this small pin of the commemoration of the 5th anniversary of this center. So you're wearing your own one, so I don't will ask you to substitute it, but I'm presenting it to you. As a, thank you very much. Thank you very much. Y a todos ustedes, muchísimas gracias por atender este seminario de esta hora extraordinaria. pero la cuestión es que tuvimos oportunidad también de escuchar algo extraordinario. Gracias a todos, hasta pronto. Buenas tardes.